It's a pleasure to argue that PreP is an essential component of treatment as prevention. And in particular, it's an honor to debate Brian Williams, an old friend from many years back. I trust that he will show us some marvelous and attractive mathematical models. I don't have any mathematical models. I do have some evidence, and I do offer this photo of a very attractive model. I think the person who goes first gets to define the terms. PreP, I think we understand, is the use of antiretroviral drugs in HIV uninfected persons for the purposes of preventing the acquisition of HIV. This can include pre- and post-exposure dosing. The agent currently approved for this indication is oral emtricitabine tenofovir. I am not going to consider investigational PreP approaches, but there are many. Oral tenofovir alone or tenofovir vaginal gel have been shown to be effective in one study each. Confirmatory studies are still being done. Non-nucleoside reverse transcriptase inhibitors, entry inhibitors, integrase inhibitors, monoclonal antibodies all have promise for prevention or PreP indications, but none have been proven so far. The approach to providing PreP could also be a game changer in this field, making it more attractive to everyone, including the possibility of having injectable PreP, nanoparticle PreP, or implantable PreP. But I think that rather than focus on future possibilities, we should focus on what we have today, because that is what this conference is devoted to doing, is thinking about using the technology that you have in your hands right now to end this epidemic. And so that's what I intend to do. When I talk about PreP, I'm talking about oral FTC TDF. But I also would like to emphasize that that the program goals for PreP are really just to offer PreP initially. PreP is one of several options for preventions, initially in pilot or demonstration projects, and that lifelong PreP use is not required or desired. So don't be thinking that PreP is just like treatment. Once someone starts, they have to continue it for the rest of their lives. That's not yet proven to be the case for PreP. In fact, we know that people move in and out of seasons of risk, and the goal of PreP should be to protect them when they need it and to allow them to stop when they don't. And so again, we're not talking about rolling out something that we don't really know how to use. What we're talking about is doing pilot or demonstration projects in as many different scenarios as possible. So in terms of background, antiretroviral therapy is required lifelong. There is no cure. Viral suppression proportions that are pivotal for the prevention or epidemiological impact of treatment run between 30 and 50%, even in the most favorable circumstances, like San Francisco and British Columbia. Acute infections are difficult to identify, hard to treat, and account for a disproportionate number of new infections. I propose that up to 50% of new infections are driven by newly infected people. Watch this number, as I suspect it will be contested by Dr. Williams. HIV programs, but there's also a social overlay to all of this that I think PreP has a role in addressing. HIV programs are underfunded and underutilized, partly because of stigma. So my argument for PreP as an essential part of TasP is that PreP is highly effective when used and costs very little when it's not used. It's proven effective in men who have sex with men and heterosexual couples, something that, as Mike Cohen and as was argued yesterday, cannot be said for TasP. Adherence sufficient for high efficacy is feasible. PreP is safe, and PreP synergizes with treatment programs. As you know, the CDC has issued guidance for the use of PreP in men who have sex with men and discordant couples and other sexually active adults. The Food and Drug Administration has approved oral co-formulated emtricitabine tenofovir for PreP indications. And the WHO has issued guidance based on what they regarded to be high-quality evidence for use in MSM and discordant couples. They proposed exactly what I'm proposing to you, which is that demonstration projects should be conducted in as many settings as possible to optimize delivery and monitoring monitoring. That should not surprise us. You all have been doing research to optimize treatment for the last 16 years. We've only had 2 years to optimize PreP. We're just getting started. Does PreP work? Yes. This is the analysis of the 2 pivotal trials that were used by the FDA to establish the indication. This is the efficacy based on the intention to treat analysis. 42% risk reduction in IPREX among MSM, 66 to 84% risk reduction in partners PreP. Confidence intervals that really give us excellent confidence that this is working and is effective. Now this, to be sure, is additional benefit above and beyond the benefits of standard prevention care. People say, well, this is relatively small compared to what we think is the benefits of condoms when used, which might be as high as 85%. But that is not the point here. The point is that this is additional benefit above and beyond the benefits of providing condoms to everyone in all of these studies. I would also like to emphasize that these are the results of randomized, blinded, placebo-controlled trials analyzed by intention to treat, including all emergent infections, even those that could not possibly have been prevented by PreP because PreP use had stopped or was never started. And in this respect, this type of data is stronger for the PreP field than it is for the treatment as prevention field, where all of the data showing efficacy for prevention comes from observational studies, ecological studies, or one randomized trial that was open label and included only those infections that conceivably could have been prevented by the intervention. Now, these were intention to treat estimates. How well does this work? How well does PreP work if it's actually used? We've been able to analyze the IPREX data, and in this graph we see the HIV incidence plotted here on the y-axis and the tenofovir diphosphate level inside peripheral blood mononuclear cells on the x-axis. And you can see that HIV risk steeply declines with relatively low concentrations of tenofovir in the cells. To be sure, this is a regression analysis of the actual data from IPREX. And in shaded here, we see the ranges of concentrations that we observed to occur with 2 doses per week, 4 doses per week, and 7 doses per week. You can see that even with only a few doses, there was a substantial decline in HIV risk and near complete protection associated with use of 4 or more tablets per week. In terms of numbers, we estimate a 76% risk reduction when drug concentrations were commensurate with 2 pills per week or use of 2 pills per week, 96% risk reduction associated with 4 pills per week, and 99% risk reduction associated with 7 pills per week. In fact, no one in IPREX became infected with drug levels consistently associated with 4 or more pills per week. To be sure, we agree with both the CDC and the FDA that our recommendation for PreP should be daily use. But these data show that this is a robust intervention and that people do not have to be perfectly adherent to enjoy substantial and high levels of protection. Now, is adequate adherence even feasible? This is a prevention indication. People are uninfected. They're enjoying a healthy life and a healthy sexual life. In fact, we do see that in some regions of the world, particularly the US, we saw 94% of our trial participants with detectable and protective levels of drug in the blood. The issue of people not taking PreP even when it was offered was mainly from settings where experience with clinical trials was minimal and people did not understand why they should take a pill that might be a placebo day after day, especially when they were also told that the pill might not work and that they have to protect themselves in every other possible way. But in the US, people do understand the value of clinical trials and the reason to take a pill that might be a placebo. How did they come to understand that? Well, it's because it was US, Canada, and Europe that established treatment in all of its optimized forms. And so they could see year after year how trials that they participated in improved the care that they received and the care that their friends and family received. People outside of these regions have had less experience with the benefits of clinical trials, and so they don't always take pills that might be a placebo. Now, the high proportion of people achieving protective drug levels should translate into efficacy, and it did. We have limited experience from the U.S. sites, but this is the experience. There were 9 seroconversions in PreP studies in the U.S. All of them occurred off PreP. There wasn't, to date, to my knowledge, there hasn't been a single PreP failure in the United States. In addition, 100% PreP efficacy was also observed in a large Uganda site of the Partners PreP study where targeted supportive counseling was used for adherence. So PreP is safe as well. There were no alterations in liver function tests, glucose or amylase or hemograms. Creatinine elevations were observed in 1 in 200 PreP users, but they were reversible and did not recur when PreP was resumed after resolution of the creatinine elevation. Clinical side effects were seen in less than 10%. They typically resolved after the first few weeks of use, typically were not dose limiting, and for the most part they were nausea and abdominal pain. We think that these are first dose effects similar to the startup syndrome that you all see with when starting antiretroviral therapy. There was no alteration in lipids or body fat distribution. There was a 1% average loss in bone mineral density that occurred in the first 6 months of PreP use, but it did not progress, and it reversed after stopping PreP. Drug resistance was not observed among those who were not infected when they started PreP. We did see FTC resistance in 2 of 2 people with acute infection when they started Truvada. Amazingly, PreP is most effective for those who need it the most. The efficacy was only observed in those who were using condoms inconsistently. And we now know why that is. PreP drug detection was more common among those reporting unprotected receptive anal intercourse and compared to those not having sex. So this is an amazingly attractive feature of PreP. It attracts the people who need prevention the most. And it is used preferentially by people who need it the most. So finally, I'd like to end by saying the ways that PreP could enable treatment. It decreases the burden on HIV treatment programs. It could motivate HIV testing by providing benefits, real benefits, to people hoping that they're still uninfected. Seropositives found in those testing programs can be linked expeditiously into care. There's more timely identification of acute infections because of more frequent HIV testing. Allowing earlier therapy initiation and enabling cure research based on starting therapy in acute infection. From a practical point of view, PreP would allow greater familiarity with antiretroviral therapy by a diversity of providers serving a diversity of people, and uninfected people may become aware of therapy in HIV. That's pivotal for spreading the good word about prevention. Most importantly, I think PreP could destigmatize therapy in the people who use it. Instead of therapy being associated with side effects and HIV infection, it would be associated with proactively taking responsibility for staying healthy. Its effect on stigma could be the game changer. And in fact, I think we all agree with Barack Obama that when new infections among young black gay men increased by nearly 50% in 3 years, we need to do more to show them that their lives matter to everyone. Offering PreP, whether or not they choose to take it, is one way to say that you matter. So, in conclusion, PreP is essential for TasP. It's highly effective if used. It's used most by those most in need. It's safe. It motivates HIV and STI testing, enabling TasP and cure research, and may destigmatize the drug and the people who use them for prevention and treatment. Thank you.